Hello everyone, this is Dr. Amr Hamza from Noor Al Yaman Eye Center, and this is a case of an 80-year-old child presented with traumatic cataract with anterior capsular injury. So exactly in the center of the cornea you can figure out there is a small self-sealed corneal puncture, and there is traumatic cataract with ruptured anterior capsule inferiorly. So I started by doing the side port and injecting intracameral adrenaline. After that, injecting Triban blue dye to stain the anterior capsule or the remains of the anterior capsule, the superior part. Doing the second side port, injecting viscoelastic and starting doing the anterior capsular excess. So I started using 23 gauge micro scissors from the part which is already opened from the anterior capsule, then using the micro capsular excess forceps I completed the anterior capsular excess. After finishing the part with intact anterior capsule, I used the scissors again to complete the part of the opened anterior capsule to complete the excess. Now doing the aspiration of the lens matter using the bimanual irrigation aspiration. After finishing aspiration of the lens matter, I could figure out there is 2 parts of extension in the anterior capsule at 5 o'clock and around 9:30 or 10 o'clock. Before removing the irrigation port, I usually inject viscoelastic to avoid the shallowing of AC and the extension of the capsular excess extension or the extension in the anterior capsular opening. You can here figure out the central small puncture in the cornea. Now opening the main wound to implant the IOL, and I decided to implant 3-piece IOL in case that I could not place it in the bag. I can put it in the sulcus safely. So IOL is in place and I could implant it inside the capsular bag safely. Securing the main wound using 10-0 Vicryl suture. After that, removing the viscoelastic and injecting carbachol to meiose the pupil, but unfortunately it didn't work very well, so I decided to do manual stretching of the iris to make the pupil smaller, so that will help me in having the IOL in place tomorrow and avoiding any optic capture. So using the microforceps, I did iris stretching to make the pupil smaller and securing the IOL in place. For now, removing the viscoelastic slowly, injecting a small amount of triamcinolone just to check that there is no vitreous in the AC or in front of the IOL. And after that, injecting air bubble also to make sure there is no vitreous. Finally securing the side port with another 10-0 Viper suture and putting subtenon triamcinolone. Thank you so much for watching.